video, we'll discuss esophageal cancer. There are two main types of esophageal cancer, squamous cell and adenocarcinoma. Squamous cell is associated with the upper third of the esophagus, is the most common form of esophageal cancer worldwide, and is associated with smoking and consumption of cured meats and very hot liquids. Adenocarcinoma is most common in the distal third of the esophagus or at the GE junction. There is also an association with smoking, as well as an association with GERD and obesity. This is the cancer that Barrett's esophagus transforms into. Be sure to watch my GERD video for more information. Common presenting symptoms are dysphagia that progresses from solids to liquids as the obstructive tumor grows larger. Hoarseness can occur, especially if the recurrent laryngeal nerve is near the tumor, and there can be hemoptysis. The first study is a barium swallow, which can show a narrowing at the obstructive lesion, but patients with alarm symptoms or at high risk should get EGD with biopsy. This EGD with biopsy is required for diagnosis. Staging is done with a PET CT to look for metastasis and endoscopic ultrasound to determine the depth of invasion. Commonly, upper cancers, and thus squamous cell carcinoma, go to the lungs and the cervical and mediastinal lymph nodes. Lower cancers, usually adenocarcinoma, most commonly go to the liver and the celiac and gastric nodes. Treatment is via surgery, but T2 and higher cancers get neoadjuvant chemoradiotherapy. Usually 5-fluorouracil and cisplatin are included in the chemo regimen. There are three main options for esophagectomy: transhiatal, Ivor-Lewis, and transitional. Transhiatal requires a laparotomy to cross the diaphragmatic hiatus and a cervical neck incision. The esophagus is removed from the pharynx to GE junction, and the stomach is pulled up to the neck where the anastomosis is made. This is called gastric pull-up. This avoids thoracic anastomosis, which is associated with mediastinitis from an anastomotic leak. Mediastinitis can precipitate sepsis quickly, so this is a serious consideration. The cons are that the patient loses their entire esophagus regardless of the extent of disease, and they don't get a mediastinal lymph node dissection. The Ivor-Lewis method requires a laparotomy and thoracotomy. Only the distal third of the esophagus is removed, and the thoracic lymph nodes can be removed, but the patient has an intrathoracic anastomosis. Finally, there is the transitional approach, including all three incisions. The cervical, neck, thoracic, and laparotomy incisions are made. The entire esophagus is removed. A cervical neck anastomosis is made with gastric pull-up, and thoracic lymph nodes can be dissected. Positive lymph nodes require adjuvant chemotherapy. Thanks for watching. Please like, comment, share, subscribe, and hit the notification bell for more great videos. Remember, if you don't want to miss it, look below and click it. Check the description for more great study resources.